Good morning. My name is Tom Partner. I'm a nurse practitioner. Today I'm going to present a lesson on non-traumatic eye injuries. There are many types of non-traumatic eye injuries, perhaps as many as 20 different types. There are dangerous non-traumatic eye injuries. Some things that can result in the loss of vision. And there are those that are most of the time will resolve themselves as given time. So we call them not dangerous or simply uncomfortable, but not as dangerous. Given that there's so many different types, today I'm first going to cover, in this first half I will cover the dangerous eye conditions. There are approximately 11 of these dangerous eye conditions. First one is a corneal ulcer. I'm going to read this list and I'm going to go over it one by one. Second one is herpes simplex virus in the eye. Third one, herpes zoster virus in the eye. Fourth one, superficial punctate keratitis. Not quite as dangerous as some of the other ones. Acute iritis, also known as anterior uveitis. Acute angle glaucoma. Seventh one, episcleritis. Eighth one, scleritis. Ninth one is orbital cellulitis. 10th one, preceptal cellulitis. And the 11th one, endophthalmitis. So, now let's look at each. Before I go into each one of these, I want to say this, that most of the time people get pink eye, it's going to be a viral conjunctivitis. However, if you're the examiner checking a patient's eye, you want to make sure that none of these dangerous conditions exist. In order to do that, there's certain tests that you can or should do, depending on how severe the initial presentation looks. Okay, first of all, there's a test where a person can manipulate the outside layer of the eye, the cornea, with a little sterile cotton tip applicator. And you move that cornea back and forth the conjunctiva back and forth to see if you're moving the conjunctiva, the red lines, the injection should move. In that way, you're making sure that you've got a problem with the conjunctiva and not the episclera or the sclera of the eye. Because the episclera and the sclera can have is a more dangerous problem for the eye. Now, since this can be sensitive, it's probably a good idea to put an anesthetic drop in the eye before you attempt to do this, so that your patient doesn't complain of pain. The second thing that a examiner should do is to carefully look at that eye and determine whether the conjunctiva or the reddened area, we'll call it the injection appears to be coming from the outside of the eye where the conjunctiva is and moving inward, or is it starting with the iris and moving outward? Okay, because typical conjunctivitis, which of course is not very dangerous in most cases, is moving from the outside of the eye to the inside of the eye. On the other hand, anterior uveitis, which is an infection coming from the anterior chamber of the eye, is usually starts with the outside edge of the iris and it moves outward. So you must take a close examination of that to make sure which way it looks like the injection is traveling. A third test is a fluorescein stain. A fluorescein stain is when a person takes a little pre-made fluorescein sample, which is on a little tab, and you wet it with a little saline, and then you pull down the eyelid, and then you put it in on the eyelid for a moment or two, maybe 15 seconds, until you see a little orange dye go traveling around that eye. Now sometimes it's a good idea to compare eyes. So you might want to do this in both eyes, although you don't have to. But what you're looking for, then you're going to take a little fluorescein, it's like a black light, a little black light of some type, and you look in the eyes and you're looking for sort of any green lit up areas outside of where the fluorescein should be. The fluorescein should be down here where it's collecting before it's going to drain out through the lacrimal duct. So that's a fluorescein stain. So that's a good way to find out if you have any ulcers on the cornea. So, and that would be cause keratitis, and that really needs to be taken up. And then usually the treatment for that can be medication, strong ophthalmological medications that go into the eye. But because it's so serious and can lead to blindness, it should be examined by an ophthalmologist and followed carefully by an ophthalmologist. Now in some cases, and not all cases, especially when the person is complaining of pain, you want to do a fundoscopic exam. So a fundoscopic exam needs to be done with an ophthalmoscope, which is where a doctor looks very closely into a person's eye. And what he's trying to find out is, what does that optic disc and cup look like? Generally speaking, in most cases, not all cases, because there's genetic variations, is the cup, which sits inside the disc, is about 1/3 of that disc. Now, like I said, there's genetic variations. This is one of the reasons that one person, you can't just look one time and say, okay, the person's, their disc is, or their cup is too big and therefore this person's got glaucoma. No, because of the genetic variations, it sometimes has to be followed. However, if a person looks in both eyes and the person has pain in one eye and not in the other, and that cup inside that disc is bigger on the side with the pain, there's pain, that's a very good indication that there's going to be some sort of increased intracranial intraoptical pressure. Most common reason for this is glaucoma, acute angle glaucoma. Chronic open angle glaucoma is a type of glaucoma that occurs more slowly over time and usually doesn't come on quickly. Another test that needs to be done is a field of vision, and the easiest, fastest way to do this is by confrontation. Basically, two people look at each other about 2 or 3 feet away, and the doctor asks the person, can you see my hands here? Can you see my hands here? And can you see my hands here? The hands are equal distance, and usually more further out to the side, but I can't show you that on this picture. This is basically, there's other ways to do this. This is why they explain field of vision by confrontation. But the examiner's hands has to be equal distance between the examiner and the patient. In this way, they should be able to see about the same amount. and assuming that the examiner has a normal field of vision, then should be able to determine if the patient has a normal field of vision. This is one of the things that will decrease the field of vision is glaucoma, but also pituitary tumor. So of course, we're ruling out some big things here. The next test is a visual acuity test. So this is basically reading a chart on a wall, or it can in some cases be a chart that's held like 10, 12 inches from the face. And therefore, this is sort of a way to rule out, is there a problem with the retina? Is there a problem with the cornea? Because if there's a sudden change in this visual acuity, that's a good indication that there's something really bad wrong. In some cases, just to let you know, that it's a good idea to have on hand a pinhole visor. I'm going to call it a visor. It's like a little black cover thing with holes in it. And the reason this is important because sometimes people present with to the doctor and they forgot their glasses. They got an infection in their eye, or they think they took the contact lenses out, and but they forgot to bring their glasses. By using these pinhole visors, it can help to correct their vision so it's almost back to normal. The exact reason this works is I don't know, but anyhow, it does work, and it's a good way to rule out any new changes in vision or vision deterioration. And if you see that, it's reason for greater concern. And the last test, which is usually not done simply because it requires a prescription of medication, is phenylephrine eye drops. This is like 10%. So Visine has the same medication, but only 3%. And basically the eye drops are put in the eye, and then the eyes are looked, that injection part is looked at. Did it become less obvious? Did it become fainter? In other words, did this phenylephrine, did it constrict those blood vessels? And if it did, you know that you're dealing with episcleritis versus scleritis. And episcleritis is less serious than scleritis. So scleritis is oftentimes due to an autoimmune disease such as lupus, rheumatoid arthritis, and it definitely can be an emergency. So that type of person would have to be sent either to an ophthalmologist or emergency room to get more immediate care. So those are the 7 tests that a doctor or examiner should be well aware of. So let's look at these 11 first most dangerous things to rule out. Okay. So the first one is corneal ulcer. So if we do this fluorescein stain, we stain the eye, we get our black light, we look in there and we see little green specks or a green area. Sometimes you can even see there's a motion to it. The green dye is moving. So in any of those cases, this is definitely something that needs to be seen quickly by either an ophthalmologist or emergency room. That's an ulcer, a corneal ulcer, and it definitely needs medications. It may need even more more difficult treatments by the ophthalmologist. The second one, herpes simplex virus. And again, you're going to fluorescein stain the eye, and you're going to be looking for irregular patterns in this green when you put your black light on the eye. It's been specifically over the area of the iris, which is the corneal area. Okay, but you can look at any part of the eye because vesicles can come and they can leave eruptions, just like they would do on the skin. So that's what you're looking for here. Now, herpes simplex virus is similar to the herpes zoster virus, but if it's on the eye, it's probably going to be smaller number of vesicles, and usually the pattern is a little bit less less regular than if you see herpes zoster, meaning it doesn't follow an exact dermatoma so much as the herpes zoster. Okay, but again, you want to fluorescein stain the eye, looking for greenish appearance when you shine your black light onto the eye. The next one is superficial punctate keratitis. And this is an injury to the eye that usually welders get. And again, you're going to fluorescein stain the eye. This time you're suspecting, or what you'll see, are speckled areas of green as due to the fluorescein. In other words, it's not one big ulcer or several ulcers that you might see with herpes zoster, but it's speckled collections of green because the general area has been received too much heat or too much light, and you're going to get that same type of appearance if somebody stares at the sun too long. Sometimes children will make the mistake or play games of how long they can look at the sun, and they can damage their eyes by doing this, and will show up as speckles over the cornea area of the eye. So another one to look out for is the acute iritis or anterior uveitis. Again, this is going to be an injection. Let's say this is the iris. The injection is going to go out from the iris, versus if you have a conjunctivitis where the injection is moving in from the outside area of the eye. It's a very good tip-off if you've got anterior uveitis, also known as acute iritis. Now, acute angle glaucoma, there's more than one test you can do for this, like most of these things. But one thing that's sort of easy to do is you can palpate the eyelid of the eye. And you can compare, if you want to check your patient's pressure to your pressure, that's a good way to make a rough determination of the possibility of there being an increased anterior chamber pressure. The second way you can do the examine for increased pressure, of course, is tonometry. But most places don't have a thermometer because tonometers are a little expensive. The third way that most places do have is to look at remember the optic cup versus the disc. And you look through an ophthalmoscope and you look at that cup and disc. Remember, the cup generally is only 1/3 of the size of the disc. Usually there should be relatively clear borders, and usually there's not any little constrictions in the arteries that are going into that disc area. So sometimes, or usually, when somebody has increased pressure in that anterior chamber, they can sort of put pressure at the side of that disc. And that can cause what they call nicking in the arteries, a little spot that you can see. There's looks like a little nick in the artery. That's because of the pressure right there at the site where that artery is passing by, and that optic disc is putting pressure on it. Also, the greater the pressure, usually the more blurred the cup and disc borders become, so that as the pressure increases, the little circumference of that cup is less easily be seen on a disc. Also, and the disc to retina also becomes a little bit blurred as well. So that's what you're looking for if you're doing a fundoscopic examination, trying to determine if there's increased intraocular pressure. Episcleritis. Episcleritis is another condition you have to be concerned with, and one of the ways to determine if you have episcleritis or scleritis is to get, like I said, a sterile, well, first anesthetize the eye with a little eye drop anesthesia. Then you get your sterile cotton tip applicator and you put it on the eye gently, and you see if you can move the conjunctiva. You should be able to move the conjunctiva back and forth, and if your injection moves, then you know that you've got conjunctivitis and not episcleritis or scleritis. So now we can narrow it down. If it doesn't move, you've either got episcleritis or you've got scleritis. Now, most places do not, as far as I know, have phenylephrine 10%. So therefore, if you're checking the area, you're checking for movement of that injection, and you don't see it, and you don't have 10% phenylephrine drops, then you have to send this person out, because you know you have to either got episcleritis or you've got scleritis, and these things need to be followed up by a ophthalmologist. They may need sterile. If there's not an infection, which this is usually an autoimmune type process, they may have cortisone. They may need cortisone eye drops, they may need cortisone steroids, or they may need some other type of medications to reduce that autoimmune reaction. Oh, there's one other clue between episcleritis and scleritis. In episcleritis, the injection usually travels in lines outward from the iris. On the other hand, episcleritis usually has mixed lines. So there's not only what they consider radial lines, but there's also these other crossing lines. Yeah, they call these other, so the radial lines and circumferential lines. With scleritis, there's also usually more pain. Episcleritis, there's not usually pain, there's usually tenderness. Another condition to check for is orbital cellulitis. So orbital cellulitis is what it sounds like. In the orbit, meaning this area of the eye, there is an infection, and you're going to get redness and swelling. And it is possible to treat this as an outpatient, but it requires, some antibiotics. However, to be on the safe side, it definitely needs to be followed up with a visit the next day or the day after that, either with a primary care physician or by yourself or by an ophthalmologist. Something that looks a little similar to orbital cellulitis is preseptal cellulitis. Now, preseptal cellulitis looks similar to orbital cellulitis, except there's inflammation here in this area, but it's not swollen. And the reason is there is an abscess deep down inside of the eye. It is not the surface area, even though it may look like the surface area. So again, this is a very difficult, somewhat difficult diagnosis, and it should be seen by an ophthalmologist or an emergency room doctor. Somebody who can look even better than you have with your ophthalmoscope and do more tests. The last dangerous type of eye problem is endophthalmitis. This is an infection, again, of the anterior chamber of the eye. The anterior chamber being the front chamber of the eye. Usually, this is secondary to surgery that's already been done in the eye. Sometimes you can look at the eye and you look at the iris, and down at the bottom of the iris you can actually see a sediment there of white blood cells. That's how many white blood cells are in there. Oftentimes may also appear as a very reddened, infected area. This person definitely has to be either referred to the ophthalmologist or the emergency room. Probably is going to need to be admitted to the hospital. Probably is going to need to have intravenous antifungal medications or antibiotics given to that person so to save their eye. So that concludes my lesson on the most dangerous eye problems. There are, remember, and I'm going to go over it shortly, about 9 other types of eye problems that are not that dangerous. But just real quickly, so remember that we have approximately 11 dangerous eye conditions that have to be ruled out. If somebody comes into the office and says they got pink eye, okay, why? Is it a corneal ulcer? We stain it? No, we don't see any ulcers. Is it herpes simplex or herpes zoster? Again, fluorescein stain, if you don't see any ulcers or any discoloration, probably not that. Superficial punctate keratitis, same thing. We've been looking for speckles, a little green when the fluorescein stain is put under the black light. We don't see it. It's not that. Look at the iris again and look for injection coming out. If you don't see that, then you probably don't have acute iritis or anterior uveitis. Glaucoma, you do your fundoscopic exam. If you can see a nice cup and a disc, and the cup's only about 1/3 of that, then it looks beautiful, then you probably don't have that. Episcleritis and scleritis. If you take your little cotton tip applicator and you can move that injection, then you don't have episcleritis and scleritis, and you can exclude that. Orbital cellulitis is basically looking at that outside area just to make sure that that's not what the person is complaining of. And if most of the time people know they're talking about the inside of the eye, not the outside of the eye. But if it's the outside of the eye area, then you can be concerned that it's either orbital cellulitis or preseptal cellulitis. If it's not, then you can again assume that it's something less dangerous. And the last one, of course, was endophthalmitis, which, like I said, is pretty bad looking and oftentimes will have sediment at the bottom of the iris. It can be seen by the naked eye and looks pretty bad, and this person would have to probably go to the hospital and get IV antibiotics. So, thank you for watching. This is the end of my lesson on dangerous eye conditions. Stay tuned for the second part, which will go over the non-dangerous or less dangerous eye problems. Thank you.